Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with John. How are you doing today?
Hey, great, Dennis. Thanks for having me.
Oh, perfect. My pleasure. So since it's the first time on the podcast, would you mind just doing a real quick introduction of yourself?
Yeah, of course. So I'm John McClellan. I'm a surgeon with the Joint Medical Unit at Fort Liberty, North Carolina. I did my training out at in medical school at USIS, training out at Madigan Army Medical Center for General Surgery. Did my fellowship training in trauma, critical care, and burns at Harborview, which is part of the University of Washington group at Seattle there. And then I moved out here to North Carolina almost 2 years ago now, and been working with the unit, and then also with the with JMU, and then also my clinical time's done mostly at University of North Carolina at Chapel Hill.
Perfect. Well, you're definitely the guy I need to talk to, because I would like to talk about TXA and trauma and kind of what happens like after they leave my hands. You know, I never really get to see what's going on. So I'm sure you have lots of experience receiving patients with TXA on board, giving TXA to patients. So if you wouldn't, maybe just at a base level, like what is TXA and like what does it do? How does it work?
Yeah, I mean, that's a good question. So just kind of, I'm glad you had that disclaimer in the beginning of your podcast that talks about, this is the opinions of people that are, talking, just you and I, Dennis. But, TXA is, been around for a really long time. It's probably one of the most studied kind of hemorrhage control drugs out there. Honestly, it's been around, and then they've studied it originally in the kind of elective world. So it was done with, spine surgery, cardiac surgery, orthopedic surgery still uses it, and they use it a little differently. So someone got a bright idea not too long ago, which really started with the CRASH 2 trial of looking at it in trauma, and how is that beneficial for us? But basically TXA is a lysine analog. So it reversibly binds to plasminogen, which then prevents plasminogen being converted to plasmin that doesn't allows the clot to be stable and doesn't break down. If you give it in various doses, it can actually cause irreversible binding to plasminogen too. So that's one of the things that, how it's so effective, and it prevents hyperfibrinolysis.
Okay. Like, at least from my point of view on the ground, essentially it's like a trauma patient, give them TXA, right? Is that really the right way to look at it? Or are there different patients that it would actually benefit better than others?
Yeah, and I think that's where, the CRASH 2 trial really gave it to non-bleeding patients too. So if you look at it across the board, I mean, the ideal patient for this is anybody that you suspect that would have to undergo a massive transfusion, in which, various institutions and organizations have a definition of massive transfusion. I kind of think of it as anything more than 4 units of, whole blood or product, of the equivalent 1:1:1. But anybody you expect to have a massive transfusion protocol initiated, either, potentially out in the field, but by the time they get to the hospital, that protocol is initiated. That's probably the population I would, really shoot for.
Okay. I mean, and that absolutely makes sense. But where, I guess maybe I'm confused or what have you. Like I've seen people, they've lost an extremity. They've been bleeding for a while. They're hemodynamically unstable. We get hemorrhage controlled, whether that be tourniquets, packing, whatever. But we've controlled the actual bleeding, sources of bleeding. Hitting them with TXA, getting them with blood. And I've seen it where sometimes people are kind of confused about which needs to go first. It's almost like, well, the algorithm says I need to do this, so I'm going to do this first. Let me prep this, and then I'll prep that. And from my point of view, like if I have the hemorrhage controlled, the TXA really isn't benefiting me. Am I like completely wrong in this, or?
Well, I mean, I think that's a pretty good, I mean, we do use it really across the board for everybody at this point, because it is a pretty low risk drug in general. We can talk about some of the complications, later on. But anytime you've been involved with the TCCC and any of the guidelines specifically put out for the military, we have to make it, it has to be structured in a way that, it can be incorporated into training and really push it to the forward medics so that they know how to give this drug no matter what scenario in there. So, things I think about now, a medic out in the field that's, alone and afraid, and they don't have the hospital system behind them, especially people like things that, you've done in the past and things like that. So, getting access, controlling, ABCs, doing the normal stuff. And then it goes down to, as soon as you have that access, giving the product if you have it available with you, and then giving the adjunct medications, which, basically is down to TXA and calcium that we're really pushing hard in the field right now. So, we want to make it almost, I'm not going to say like robotic, but almost to the point where we can get to it. We don't miss the patients that we don't want to miss. Right. So maybe they put that tourniquet on that extremity, but they don't know what else is potentially bleeding. There's a blast injury and that tourniquet is on. If it was like a witnessed traumatic amputation and they put the tourniquet in a minute after it happened, yeah, maybe that patient doesn't need TXA and you can use some thought behind that. But if they roll up on a patient, he's bleeding in the field, and it may just happen a couple of minutes ago and you didn't see what happened, we don't know what other, source of bleeding that is. And you can lose a lot of blood through an extremity, as you know, very quickly. So we don't want to miss any of those patients. So I think it's good to really push this forward, and the pre-hospital TXA is a good thing in general.
Good. And that makes absolute sense. And at least when I'm teaching guys, I'm teaching them, especially something that's going to act systemically. Think about what is the risk, what is the reward? What are you gaining, what are you losing? Because there is nothing that's free. And we mentioned, you mentioned that TXA is a very safe drug. I've talked to other surgeons that are saying like, hey, the incidence of thrombotic events are increasing, and they kind of attribute that to pre-hospital TXA. So has this been really looked at? Is this just one of those things that is kind of ancillary to it? Like there's another problem that TXA is kind of getting blamed for? Or is this like kind of an inevitable thing when it comes to like giving TXA to just patients?
Yeah, I would say most of the meta-analysis done on TXA related complications have determined that, it's a safe drug to be given empirically across the board. There's always going to be the onesie twosies and of people that have issues. I mean, I can think in my career, maybe I've experienced maybe 2 to 3 complications that could be related to TXA, but we don't know really if it was or not, or was it from the traumatic mechanism, moving the patient with massive transfusion, they get a whole bunch of resuscitation, and then maybe they're teetering on DIC or some type of coagulopathy that led to those complications down the line too. So I don't personally think that the TXA, the complications from TXA are increasing, and especially the thrombotic events are happening. But now that these protocols are well established, if your trauma system isn't really recognizing that your pre-hospital providers are giving the drug, and this is very applicable in the military too. If somebody's getting double the dose of TXA, and then you run into the concerns for seizures and the neurologic events that associate with TXA. Anything over 2 grams for TXA given increases your seizure threshold significantly. So that might be something that we start to see if they're getting slammed with 2 grams in the field, and then as soon as they get to the hospital system, there's not good handoff, there's no card attached to them or something like that, and they're getting hit another again with 2 grams again, and they maybe aren't massively bleeding, so they're not losing that TXA, then it's possible that those complications could start to show themselves.
No, that's super interesting, because I had absolutely never heard of anything about seizures and TXA. For a very, very long time, it's been 2 grams, right? Initially, it was like 1 gram up front, and then we do like an 8-hour drip of the next gram. And, now it's kind of the 2 gram slam kind of situation currently. The crash 3, they're looking at severe TBI, the latest one. Was it crash 2?
Mm-hmm.
All right.
Crash 3 looked at, crash 2 is this TXA, in general, like looking at mortality, and crash 3 is looking specifically at TXA and TBI.
Yeah. But that's what I mean. In crash 3, I want to say they were talking about 3 grams. So, it seems like, all right, we went to a 1 gram push and a longer drip with the 2nd gram. Now we're doing 2 grams up front. Like, could it start going to 3 grams? So essentially 3 grams to everybody, and now we cover all our bases,
Yeah.
Where does it stop?
Where does it stop, right? As soon as it can be like 7 grams. We never know. But no, I think 2 grams is here to stay. The 1 gram and 1 gram 8 hours afterwards was always, that was derived, that was in the crash 2 trial, is what they studied in the crash 2 trial. That was derived particularly from elective procedures and people that are high risk, OB procedures, cardiac procedures, spine surgeries, where they would push 1 gram before the skin incision was made. And then they realized that maybe that the pharmacokinetics of TXA aren't going to last the length of the procedure, and they want to get more of a steady state of that levels in the blood. And let's just run it let's run an 8-hour drip, another gram over 8 hours. And that will keep TXA circulating the blood after metabolism, and it's excreted through the urine. But in trauma, that doesn't really make sense, right? So we need all that TXA now. We're talking about ongoing injury that's happening in elective cases. Maybe they work on one part of the spine, they cause a little bit of bleeding, they want that to clot off, and then they move to the next part, and they're doing that again. They're doing that over a period of, potentially 4 to 5 hours. And trauma, that injury's already happened. So we need to increase those levels of TXA in the bloodstream as fast as possible and get to, it absorbs very quickly through the IV, obviously. It's already circulating. But we want to get those levels high. And that's where 2 grams came from. I think 3 grams, I don't have the study in front of me looking at that, but they didn't see any benefit to the higher number of drug. I don't remember in that study specifically if they had an increased number of complications with 3 grams. But you look at some of the pre-hospital TXA literature, and they show like seizures increased, with the 2 gram group when they look at it, pre-hospital administration of TXA for TBIs. They were saying, hey, maybe the seizure threshold is a little higher when you're giving, push dose. And then the other complications with anytime you're pushing large amounts of TXA, you got to be worried a little bit about some transient hypotension too, which then in trauma, that's just going to lead to further resuscitation, more blood products, and you start to further cloudy and make your picture of what this patient is happening to this patient very difficult. Is it more bleeding, or is it the medications you're pushing that's causing hypotension?
Right. So that specifically, I called one of the helpline for like Pfizer or one of the companies that make it. And I asked them specifically, like, what mechanism causes hypotension? Because, when you look at the insert, like all over it, like may cause hypotension, like all over it. It's like, well, like, I'm not very smart. Like, what mechanism does this work? And they said, like, there really is no mechanism. It just happened and we had to report it. So, So it makes me wonder, whatever trial or whatever study they did to get this actual information to make the insert, was it a guy that, he had a street sign parked in his chest, we're throwing the kitchen sink at him trying to save his life. We happened to give him TXA as well. He got hypotensive and he died. Or is it somebody like, we're doing good work, things are coming back, somebody gives him some TXA, and then for absolutely no reason whatsoever, he became hypotensive and he died. So I'm wondering, is it really, causality, or is it just associated with badness because it's trauma and that's what happens?
Yeah, that's a good question too. it comes up occasionally in the trauma bays, when we're dealing with a very sick trauma. Maybe it was we're pushing the 2 grams as they enter the door. Just as a caveat there, like what I'm seeing still in most pre-hospital providers in the civilian side are giving 1 gram, and then we're finishing the patient off with the 2nd gram when they get to the hospital. It seems to be the kind of going thing around this area. Sometimes you'll have that, that one person that's pushing 2 grams, which is fine. But, it always comes up when, we're actively resuscitating a patient. The big thing is getting access, trying to get product on board, and then we're slamming all these medications into them. And what really caused the hypotension? I don't know. I mean, the pharmacist might be like listening over my shoulder and it's like, oh, it's the TXA did that because that's a known thing. Just to say it's on the box, might cause hypotension. But I don't know really if it is or not. And, most of the literature that, studies TXA doesn't really report hypotension as a significant side effect. So I'm not sure. It probably has been studied a few times before, but I'm not sure if I see it clinically.
Yeah. And I always wondered, because I can't figure it out, like how this would happen, because it's not acting on the vasculature, it's acting on the clot itself. But then again, I have a public school education, like, it falters sometimes. But
well, there were some people there's some people who thought, that TXA might have some effects that we don't really understand, right? So, it definitely has it's the lysine analog that binds with plasminogen, prevents clot breakdown, right? We do know that, like we can study that, we can show that. But there's a question whether it helps seal the endothelium too, which is basically the lining of your vessels. And when you're doing that, does that cause some unwanted effect of hypotension or vasodilation that could lead to something like that? These are all, kind of discussions in the background that, doesn't have a lot of literature behind it. But I think, it's a good thing in general just to think about all the medications you're giving. And TXA is pretty solidified in the trauma world at this point. And think about how these medications came to be, right? Like calcium and TXA, two of the mainstays of where we use in the trauma centers. And what are are there effects that, we're so solidified in medicine, like these are the things we have to do, but like, is it really, do we understand everything that we do all the time? And I don't know if I can honestly say that, because there might be things that we don't know that we're doing that are happening that either benefit us or don't benefit us. We don't know. And that happens routinely throughout the history of medicine and surgery.
Oh yeah. I'm sure, did the patient live because of you or despite you?
Yeah, that's a good way to put it.
Earlier we were mentioning like the gram up front, the drip over time, which kind of leads into one of the new T-Tri-C updates that hasn't really been like solidified yet, but it's definitely been a thought for quite a while, is IM dosing of TXA. Now, if you're talking about a healthy person, that makes perfect sense. Like it will get into the vasculature, you will get your plasma levels, it'll do as advertised. But in a trauma patient, they're shunting, they're losing their blood in the skin, they're losing their blood in the muscles, all going to the core. I guess I don't really understand, like, why is TXA okay in this situation when all the other medications that we talk about, narcotics or antibiotics or whatever, in that type of patient, it's not recommended?
Yeah, and that's a great question. Originally the discussion in a study that I was a part of is whether, we could just even give TXA through an IO. I mean, that was like the first discussion on this. That was shown to be about equally as effective as giving an IV. So we know that's the case. I think with all IM medications, and when there's an IV or intraosseous option, it's going to be less effective. Now, IM TXA really hasn't been studied on a super large scale, but we know it's safe. And we know that, to really truly shunt, from the periphery of your skin, you gotta be, probably in your higher classes of shock, 3 or 4. It kind of And that also depends on if you're dehydrated, cardiac output at the moment. And that's why it's so important to give that TXA early. So, if a patient arrests, the blood's not going anywhere. So even the TXA it's given IV is not going to do anything. So they try to give it early. The one challenge that, I haven't ever given IM TXA. I work in a hospital center. I put central lines in a decent amount. So I can get access in most ways, right? But the one challenge is that, you've seen the TXA vials and how much of a push that is. Getting it all into an IM space could be difficult. So you have to kind of split that up into different areas. There was some discussion. I know that the TCCC guidelines recommend IM if you can't get IV access, which I think is a very fair, and I think that's an appropriate recommendation. But there has been some discussion prior, I don't know wherever it ended at, but some, auto injector options for TXA through the IM. I kind of heard about that 2 or 3 years ago. I wasn't really involved with it. And then not really sure where it happened. It probably came down to some sort of packaging problem or, safety or efficacy issue that, handing out these auto injectors. So if somebody was hit, they just grab it out of their pocket in the pants and put it into their leg, and there you go. You got some TXA on board. So, but I'm sure that there's some type of safety issue with that.
Yeah. Probably the FDA or something.
Yeah.
But I mean, especially if we're talking like, hey, at higher doses. So I think you mentioned like higher than 2 grams, your risk for a seizure starts to go up. I can just imagine, because I remember this when we had the morphine auto injectors, like early GWAT, and guys would stick themselves. Not much would happen. Either they didn't have the patience to wait, or the guy had the tourniquet on and nobody recognized it till after the fact. And then they stick them again. And as you can imagine, once either that tourniquet came off or they got them somewhat resuscitated, then they found the morphine, right?
Yeah.
I could imagine something fairly similar with TXA. So yeah, we hit him with the TXA auto injectors. Nothing's really happening. He's still bleeding. Well, screw it. Send more. Now we have access, so we get it in. He starts to get resuscitated, and now we find the TXA. You know what I mean? Yeah. I don't even know if that's a valid thought.
That's a good thought question. I don't know if the TXA would still even be viable at that point. I mean, the opioids to the morphine, sure, like I would assume so. Like the opioids, definitely, obviously you've seen it, so that's a thing. But I'm not sure about TXA. Would be an interesting thing to study. But and that's probably why we don't have auto injectors for TXA, because they've seen auto injectors used for other things. They're like, oh man, maybe we don't want to throw this one in there too. But there's probably way more to that story than I'm aware.
I mean, I've made a business out of being paranoid and thinking of like the 7th and 8th order effect of what's going on. So that could easily be like never a problem ever. And I would still think about it. But
that's a good,
another, I won't say issue, but is like timing of it. So, they say, never give TXA after 3 hours. Understood. Which, especially with the initial dosing, always kind of confused me when it's 1 gram up front and then an 8-hour drip, which obviously is going to take you way past your 3-hour window. But, I drank the Kool-Aid and just did it the way they wanted it, because I didn't want to think that hard about it. But what I do see happen, we have a patient who's bleeding. We get somewhat control. We've done the TXA. We've done a resuscitation. Like things are quasi-stable. Some reason in transport or for whatever reason, the patient starts bleeding again. And the question always comes up, like, can I hit him again with TXA? Is this a new bleed? Did I restart the clock? Is it like, when is it okay? And obviously I have no labs, so I can't tell. did the TXA, the original TXA, wear off? So in that kind of situation in transport, patient starts bleeding again, hemodynamically unstable again now. Would you send the TXA and or would you be like, nope, 3 hours, we're not touching it no more with that anyway?
Yeah, so I guess maybe to understand your question, maybe the TXA wasn't given initially. Well, it was given. Okay, and now you have a new bleeding episode on top of that. Okay, yeah, that's a good question. I think that, that kind of leads into, the way I use TXA and just understanding the pharmacokinetics of TXA administration, right? So we think that just by a study that we did in large animal studies, about 25% of your viable and active TXA will be washed out in a transfusion model, or a hemorrhage model, right? So we have to. That was one of our big questions: is do we need to redose TXA at interval times in the operation, especially when we have more than 25%, or maybe I'd say a quarter blood loss or half blood loss after a certain number of units that are given. And the patient's doing. I think it's very reasonable to do that if there's ongoing bleeding. So take that back to your question. I would say yes, redose that patient with TXA. If it's just minor skin bleeding, but if it's enough bleeding to cause hypotension, I would say I think that's a very good reason to redose that TXA.
Yeah, I mean, I could see something like fracture liver or spleen or something, and then just during transport something opens back up, and then that question comes in well, I can't do anything else other than give blood, and I don't have lots of it, so I need literally any other help I can get, and this is where I'm at.
Yeah, and you bring into one of the big questions that I'm just generally interested in too. I've never been a combat medic. I've never been I've done this my entire life as a surgeon, but one of the big things that I've always tried to understand is people like yourself and your job, right? Because it's so easy for us to make recommendations for administration of drugs and things like that when we have a hospital standing behind us, or even just a few more team members in my military job to help with things, right? So we try to make it practical use. And that is something of big interest in outside of TXA too, just in general. How can we make this for the one person that's alone and afraid out there trying to do this by themselves, manage, in a mass casualty situation. And I think that goes back to why we have the TCCC guidelines and why we make it very standardized. And I know, that there's a lot of thought for that exact purpose put into it.
Yeah. Perfect. Yeah. It's gotta be. So, an example, like a lot of the guidelines, when you read it, you can tell they have a particular patient in mind when you wrote these guidelines. Unfortunately, I don't always have that patient. I have one who's 4 or 5 degrees off of that patient. And so that's when you really start thinking am I doing the best for the guy that's in front of me? So I think, whatever direction people need to go, especially when it comes to guidelines, is maybe even lay out this is the patient we're kind of basing this off of, just to give context to this is why we're recommending this.
Yeah, no, that's a good way of thinking about it too. And that's why I always like doing this when I'm in a deployed environment too. I love, sitting down with the medics of all different skill sets and, running these scenarios, because it's impossible to teach the intangibles of what scenario you're going to have. And, a perfect trainingism is to keep developing patients that the medic or any provider for that matter hasn't ever seen before. So then when the time comes to actually see something at least similar to that, they remember what they did and what worked and what didn't. So, but yeah.
So again, you have lots of experience. My ears are wide open. When it comes to TXA, let's say you're talking to that young medic who is going to be alone and afraid. What would you recommend when it comes to TXA. Like, do I hit them first with TXA? Like, that's another situation is guys are like preloading like 20 ml syringes of TXA if they have the supply to backfill that, because it's not going to last that long in there. But and they'll get their IV and they'll use the TXA to just flush it, versus using like a saline or whatever, and then connect their blood and then start resuscitation. So, is that recommended? Don't do that. Do that. That's awesome. Like, there's always a bunch of confusion. So just your opinion, like, how soon should I be using this TXA, and like, what is the right person for this?
Yeah, and I think, and I'm just kind of generalize it for the pre-hospital setting in general to kind of talk with civilian side and military side. I think preloading TXA is an exceptional idea, and it's a good preparation, because the one thing we don't want with TXA in basically any type of other pre-hospital intervention is to delay that transport to the next level of care, right? We know that if we can get patients to a surgeon or a trauma center or whatever you are in the military, at least a team outside of yourself, we can improve care and outcomes with that kind of thing. And also offload you so you don't have to take care of so many other people too. So anytime, I think if I'm not sure what the pre-hospital providers in the civilian side do, if they're allowed to preload, that's outside my knowledge. But I think preloading it and running it in and giving it as 2 grams right up front, right as you have a new trauma patient, I think that's very fair. If your organization, I wouldn't use John's recommendation, as I would look at your organization and what that recommendation. The military, I know it's 2 grams. That's easy. Everybody has to do that. And for the paramedics and the EMTs out there, I would look at what your organization, what they recommend, obviously, and give that, because you don't want to go outside the standard of care for whatever you set as your protocol.
Nope, definitely wise advice. Any other thoughts or any other kind of myths out there with TXA?
No, I think TXA, we talk about all these things. I don't think I have the years yet to really see the ebb and flow of a lot of these, hemorrhage medications that we have, but it has been one that's really stuck around for a long time, for many purposes, because it does show, it's really shown and it's solidified as a medication that shows effectiveness if given within 3 hours of bleeding. You kind of briefly mentioned what happens if you give it after 3 hours, right? Really, the two big things are it's not as effective. The multiple studies have shown that if you give it after 3 hours, you're not really getting the benefit of that medication. And then those risks of TXA start to come into play. Like, should we be giving this medication? Do those risks now outweigh the benefits of TXA? And then secondly, there are actually some studies that suggest that TXA given after 3 hours might have increased bleeding. That is, and that's like, that's kind of hard to say. And that's a suggestion, not like a proven fact. And not many people will study a medication that may increase bleeding or increase hemorrhage. But the final word on it really is that, you see factor 7 PCC, 4-factor PCC, and 3-factor PCC come into play, and all these new things that pop up. But TXA has really kind of solidified itself as a trauma drug at this moment.
Yeah, perfect. Any other thoughts?
No, I think that I'm always happy to answer any further questions on things. We didn't really deep dive too much into the papers and really looking at a practical use for TXA. And how you would do it. But always happy to answer any further questions.
I appreciate it. Hey, thank you, John. I really appreciate you coming on.
All right. Thanks, Dennis.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee. Links in the description below. And stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.